And during the next, yes, and during the next 30 minutes, I think we will have your valuable talk, and then we have a time for questions or any comments that there will be. Sorry, I lost your.
I'm here now. Sorry. I want to thank you very much, Professor Assaf, for the invitation and also of the possibility to speak in front of our friends, of the Iranian colleagues of dermatology, and as I understood, maybe also some oncologists or radiotherapists are also on board. However, I'm open for all the topics I mentioned in my presentation to discuss. And as asked by Professor Assaf, I'm speaking about recent advances in Mycosis Fungoides treatment and focusing especially on the advanced stage of the disease. You see my slide?
Yes, yes. Of course, now I can see it's written Helios, I think.
You see what?
Your slides are, okay.
The first slide.
Yeah. Some of the audience unfortunately have some problem for attending. I'm answering them.
Okay, I go on.
Yeah.
So these are my my disclosures. So cutaneous lymphoma are a broad group with different clinical and histological presentation, and because of this also having different types of prognosis. That's why the most important thing at the first stage is to define the right entity. Once we have especially seen advanced stage of disease, we have to differentiate it if it's a tumor from a classical mycosis fungoides, so it's an advanced stage of mycosis fungoides, or is it a solitary tumor due to a cutaneous form of anaplastic large cell lymphoma, which usually have a good prognosis. It's the same for patients with erythroderma. If they have erythroderma without blood involvement, so it's a erythrodermic stage of mycosis fungoides, which has a much better prognosis than erythroderma with blood involvement in the form of a Sézary syndrome. And here you see it on the first glance that patients with mycosis fungoides usually have very good prognosis. On the other hand, patients who have a blood involvement with erythroderma, in case of a Sézary syndrome, have a very reduced overall 5-year disease-specific survival. And the same, if you look to patients with anaplastic large cell lymphoma, you see the 5-year disease-specific survival rate is 95%. So it's very important to know which is the exact entity before you go to the next step, that you stage the patient. Staging is something special in cutaneous lymphoma compared to solid tumors, since we have a staging based alone on the skin type of involvement. So if it's a patch, black stage, it's early stage 1A, 1B, if it's more than 10%. Or if you have, once you have a single tumor nodule, the patient is already in stage 2B, which is an advanced stage disease with reduced overall survival. Then you see stage 3 in erythroderma, and stage 4 if the patient has blood or organ involvement. Organ involvement in mycosis fungoides is something which is very, very rare. So once you find a classical patient with mycosis fungoides, when you see infiltration of the liver or spleen, then you have always to think about a secondary lymphoma, and you have to take a biopsy from the systemic involvement to define if it is really an organ involvement, which is I've seen very rarely in my life, but most commonly I see a secondary lymphoma, which could often be like Hodgkin's disease. Most patients we see have an early stage disease, which have usually very good prognosis. And in early stage, the progression to systemic disease risk is less than 5%. That's why the 10-year survival rate is about 97%. So the patients in the early stage of mycosis fungoides, they are not dying due to the lymphoma, they are dying with the cutaneous lymphoma. So it's nearly the same as patient whereas, let me say, psoriasis vulgaris, which is usually a lifelong disease, and the patient usually is not dying due to the psoriasis, but with nearly the same is in the early stage. But completely different, and it is the top focus of our talk today, is once we have patients with advanced stage disease, as you see on the right side, patients with tumor nodules, where the risk of to progress to systemic disease is very high, with 40%. The 10-year survival rate is dramatically reduced only to 42%. So the right entity is very important. Then the next step is, of course, the staging as in other cancer. And then we can go for the treatment. And the treatment is, beside the entity, also stage adapted. You see, we have a lot of treatments as an armamentarium, which we can use. So in the early stage, phototherapy is still the treatment of choice, which can be combined with topical treatments like topical steroids or topical chemotherapy like the clomidine gel, or if available with topical retinoid. And if the skin-directed therapy alone is not effective, then we can add systemic treatment, which would be first line like retinoid, bexarotene, or interferon. And for the advanced stage, we are usually using the new available antibodies, which will go in more in detail, like the brentuximab and the mogamulizumab. And if needed, we use also chemotherapy. But once we use chemotherapy, we use usually only single agent chemotherapy, which is very helpful and for our old patients very tolerable. We have learned a long time ago, in 1989, there's a publication by Kay et al. In the New England Journal of Medicine, that combination of chemotherapy like CHOP doesn't bring any advantage for the patient in terms of progression-free survival or overall survival. That's the reason why, if we use chemotherapy, we recommend usually single-agent chemotherapy and combination only for salvage therapy. Then in these cases, you can, if you have no other possibilities, CHOP or CHOP-like regimen. Sometimes it's difficult to know which would be the best systemic treatment to choose. And for this, the idea of the compartment-adapted therapy could be helpful. That means we have treatments which are very effective for skin involvement. We have treatments which are very effective for blood involvement. And also, we have treatments which are very effective for tumor nodules or lymph node involvement. And I modified the scheme, which was published last year by Mycosis and from Stanford. And you see, just as an overview, if we have primary skin involvement in the advanced stage disease, treatments like the CD30 antibody brentuximab, or if available, the HDAC inhibitor, romidepsin or balatuximab, are very effective. Also, radiotherapy like total skin electron beam therapy or gemcitabine is also effective if needed as a chemotherapy, and if we usually recommend it to use it as a low dose. On the other hand, drugs like mogamulizumab, which is very effective, as you see here for blood, it's also effective for the skin, but it is a little bit more less effective compared to the others. And coming to the blood involvement, like having patients with Sézary syndrome, brentuximab vedotin is also working in the blood, but not that good as an example, the HDAC inhibitor romidepsin or the anti-CCR4 antibody mogamulizumab. And for tumors, we know that brentuximab vedotin is very well active, whereas mogamulizumab is not so good for tumors or large cell transformation. And of course, radiotherapy is very effective for tumor nodules. So I want to extend the idea of an entity-adapted treatment first, and second stage adapted treatment, also to adapt it to the compartment, to check which compartment is primarily involved. Is it skin? Is it lymph node? Is it blood? And then to think which treatment is most effective for this compartment. And it's also very good basis for once you want to use combinations. What I'm doing for the early stage, I just want to give you that overview. Standard treatment are still skin-directed therapy in the early stage, 1A to 2A, which is phototherapy like UVA or Dermat UVB. Or you can also use as a first-line treatment topical chromatin gel, which is like topical chemotherapy. It's an alkylants, which has no systemic resorption, so it works just on the skin. And you can use, of course, first-line topical steroids, or if available, also localized radiotherapy. And as I mentioned, we have time in these patients because progression is very rare in this patient. It's very important also to inform this patient about this perfect, or let me say, his very good prognosis. Second line, once skin-directed treatment alone is not that effective, then you can combine it with systemic treatments like first-line retinoids like bexarotene, but you can use also other retinoids like acetylene, alitretinoin, or isotretinoin. We know, meanwhile, there is not that class-specific effect of bexarotene, which is an RXR receptor, compared to the other retinoids. And in my hands, my experience, they're working nearly equal, but the side effects, of course, are different. And interferon alpha, which we now have only as a pegylated form. Or total skin electron beam is also a treatment of choice. Or use of the newer antibodies like the mogamulizumab or the brentuximab vedotin or low-dose methotrexate, which is also effective. Now, I want to go more in detail because Professor Assaf asked me more about the new treatments and especially in the situation of the advanced stage. And for the advanced stage patient, where we need really effective systemic treatment or also radiation therapy, the main 4 columns of treatment are the 2 new antibodies, which is the brentuximab vedotin or the mogamulizumab, or single-agent chemotherapy like gemcitabine, where we have very good experience, or also radiotherapy, which is very effective as localized radiotherapy if you have single tumors, or total skin electron beam in case if you have disseminated lesions on the whole body. And I want to go with you step by step with these treatments. I want to start with gemcitabine. Gemcitabine is everywhere available. It's a very cheap treatment. Hematologists, for them, it's a very old drug, having huge experience. And we know also, meanwhile, that, let me say, about 20 years, it's also very effective in the advanced stage of Mycosis Fungoides. They're very good work from Pierluigi Insani from Bologna, who showed response rate about 50-60% using the normal dosage, which means you give it 3 times a month, day 1, day 8, day 15, with a dose of 1,200 milligram per square meter body surface. We have learned in the last year that you can get the same effect if you give just half of the dosage, which means about 1,000 milligram absolute on day 1 and day 15. And we are gathered our data from our German cutaneous lymphoma network together. This is one of my patients with the advanced tumor stage, and you see also this ulcerated tumors, who initially came to me to find a special wound dressing to reduce the pain. He didn't believe that his situation could be treated. And below you see the results after 6 cycles of low-dose gemcitabine, which worked for about 3 years in this man. In our study, if you compare progression-free survival, you see the red curve is only the half dose of gemcitabine, which we call low-dose gemcitabine. And in blue is the study from Marcia et al., which is from the study group for Pierluigi Insani from Bologna. And you see the results regarding progression-free survival. And Of course, there are two different studies. It's not one study with two arms. So the comparison is difficult. But if you just look to the data, you can see that in red, the progression-free survival is definitely a little bit better with a half dose than in blue with a full dose. And the primary reason is that patients with a half dose, they tolerated quite well the treatment, and in all patients, we didn't need to terminate it pre-early because it was well tolerated. However, in the full dose, nearly half of the patients we had early to stop the treatment because of the side effects, like leukopenia or elevated liver enzyme, or also kidney problems. So once you use it, it works quite well, and the half of the dosage, like 1,000 milligram absolute on day 1 and day 15, works very well in our usually advanced age patients. So if chemotherapy used, we recommend to use it as a single agent chemotherapy, like gemcitabine, or if available, also pegylated doxorubicin. Coming now to the radiation therapy. It's a very old approach, but the big difference is in the earlier times, when I started as dermatologist at the end of the 90s, we used high dose radiation. That means we used 36 gray and more, which was effective. But however, the side effects were very often like erosions, ulcerations. And the first two patients I saw at my initial dermatology time in Berlin was that the patients got disseminated ulceration, both got sepsis, and one of these two patients died. Then from this time, this treatment was not really an alternative for me. However, in the last, let me say, 8 to 10 years, we learned initially from our friends from Lena Specht from Copenhagen that low dose is also working very well. And here you see a study from London, from Steve Morris, who treated patients of different stage, early and advanced stage. And this you see on the left is a so-called waterfall plot. And you see in blue that all the patients are responding. And you see on the first glance that nearly most of the patients respond to the treatment on the early and also the advanced stage. And on the right side, you see that it's also ongoing response for several months, usually at least 6 months, sometimes to 1 year. And it's very well shown in the study that it was well tolerated and that the side effects like blistering or erosions, ulcerations or infections or edema was much more or less compared to this high dose regimen used in history. This was one of our first patients about 6-7 years ago when we established this treatment in our hospital, where we used at this time 12 gray total skin electron beam, which means 6 times 2 gray, like Monday to Friday, then the weekend we have a break, and then we give it Monday, and that's it. And after this period, you see very fast response. I don't know any treatment which shows such a fast response like total skin electron beam. It's still the same patient. What we have learned, which is what is new in the last years, especially in the COVID time, where we tried that the patient is coming not too often to the hospital, our colleagues with Chalid Assaf and Professor Eich from the University of Münster, of the Department of Radiotherapy, they tried to give the patients only 8 gray, so 2 by 4 gray. And they nearly saw the same response as patients with 12 gray. There are larger studies are ongoing, and I think in the next week there will also be one prospective trial published. I have seen the results already. And what you can say is that the response to 8 gray total skin electron beam, so just 2 radiations by 4 gray, is nearly the same as the patients receiving 12 gray total skin electron beam. So it's very valuable treatment. It's well tolerated and provides early response, and also early reduction of pruritus and improvement of quality of life. Coming to the extracorporeal photophoresis, treatment, it's very old, from the 1987. In the picture you see the new device, or not that new, meanwhile it's about 15 years old, the Celix machine. And it's a treatment where you use it for 2 days, every 2 weeks or every 4 weeks, and it works especially well in patients with erythroderma or Sézary syndrome. And new data show also that it's one of the rare treatments which provides improvement also regarding overall survival. Just as an example, one of my previous patients who got extracorporeal photophoresis as a monotherapy, you see a patient with Sézary syndrome, and after 6 cycles, you see just on his just one single plaque, and it's well tolerated, and it's also an ideal combination partner, as an example, first line with retinoids or with interferon. And now I want to come to the new treatments which has approved in 2018, which is the fusion protein, the brentuximab vedotin, which is targeting the CD30 molecule, and the mogamulizumab, which is a full monoclonal human antibody, which is targeting the chemokine receptor 4. And meanwhile, we have huge experience with this as a monotherapy, and also increasing experience regarding combination therapy with these 2 antibodies. Let me start with mogamulizumab. As I mentioned, it's a full human monoclonal antibody which is targeting the chemokine receptor 4. The chemokine receptor 4 is expressed on the surface of the malignant cells of the Mycosis Fungoides, so destroying the tumor cells directly. And it's also expressed on the so-called T regulatory cells, leading to the depletion of the T regulatory cells. And once you deplete, that means reduce the T regulatory cells, then you have better immune response. So we have 2 effects. That's why Wilcox called it in the title, to get 2 birds with 1 stone. Why targeting this chemokine receptor 4? Because it is expressed in nearly all types of cutaneous T-cell lymphoma, especially in Mycosis Fungoides and Sézary syndrome. It is approved only for these 2 diseases, Mycosis Fungoides and Sézary syndrome. And since it's a fully human antibody, it's a classical ADCC reaction, and it works quite very well, especially in the blood, but shows also promising responses in the skin. For this, we had the largest clinical trial at all for cutaneous lymphoma, with more than 300 patients. And the new antibody was compared with the HDAC inhibitor vorinostat, which is a first-line treatment in the US. And treated were patients, half of them had a Mycosis Fungoides, stage 1B to 4B, and the other half of the patient had a Sézary syndrome. And the primary endpoint was to look for the progression-free survival. And you see in the result that the progression-free survival in red is about 7.7 months, compared to the vorinostat, to the first-line HDAC inhibitor, which was only 3.1 months. So we have more than a doubling of the progression-free survival. And that's the reason why the FDA approved it at the end of 2018. And meanwhile, it's, at least in Europe and the US, an available standard treatment. Here you see it also, the responses compared by stage, and you see that the mogamulizumab is working better regarding overall, regarding progression-free survival in all stages of the disease, and also including blood involvement. And what we have learned, that it works especially good in patients who have blood involvement. I'll give you just an example, one of my, here. This is my first patient. I treated in June 2020. The reason is, in June 2020, it was the first time available in Europe although approved at the end of 2018, it was distributed in the US, and they used it so often that they left nothing for Europe. And for us, it was available in June 2020. Then I treated this patient with a Sézary syndrome. The diagnosis was erythroderma, and you see the blood involvement, 66% of CD4 positive, CD7 negative, CD26 negative malignant cells in the blood. So it's a clear-cut diagnosis with erythroderma, blood involvement, lymphadenopathy, severe pruritus, often relapsing bacterial superinfection. What was the background of this patient? The first diagnosis was in 2016, although she had clinical symptoms 2 years before. But you see, also in Europe, we need about 2 to 3 years sometimes to make the first diagnosis, especially in the early lesions or early stage. In 2016, we had for the first diagnosis at this time of erythrodermic MF. It was not the full picture of Sézary syndrome. And accordingly, she was treated according to the guidelines with Pruva combined with methotrexate. Then she came to our hospital where she got extracorporeal photopheresis in the beginning as a monotherapy, then in combination with interferon alpha. And since it was not that effective, we changed the systemic treatment to retinoid, in this case acitretin. And then we treated her with the CD30 antibody brentuximab vedotin. And in June 2020, we gave radiation. And once the mogamulizumab was available, we started with mogamulizumab. And she showed already within 6 months a complete clinical remission. And the pruritus improved already after 4 weeks. And since this time, she is under continuation of more than 4 years under treatment. And we have a complete remission on the skin and also in the blood. Meanwhile, we extended the administration of the treatment, which is usually every 2 weeks. So in the beginning, the first 5 weeks, we give it once weekly, and then every 2 weeks. But now she's in complete remission. She's getting it every 4 to 6 weeks. But we are doing the clinical controls, including also the control of the blood involvement. What is important and also for us new regarding the side effect of mogamulizumab, it's a special skin reaction, which is called the mogamulizumab associated rash. It's about in 1/3 of the patients, 20 to 30% of the patients are getting this rash. And sometimes it looks a little bit like a drug eruption. Sometimes it looks like a relapse of the disease. However, once you look to the histology, we see a reaction predominating by increasing of CD8 cells and also macrophages. And sometimes you have giant cell reaction. So it is not just a normal drug reaction, it is an immunological reaction. And based on this, why I say it's immunological reaction, we know meanwhile that patients who are getting this rash are responding much better to the mogamulizumab compared to patients without the rash. So in terms of overall response rate, we have meanwhile several studies. We see that patients who have this mogamulizumab associated rash are responding about 3 to 4 times better than patients who are receiving mogamulizumab but not getting this rash. So this is very important to know. How to manage, how to diagnose the rash and how to manage it. There are different ways. However, there's just a publication, we published it 2 weeks ago. It's already online, where you can read all details about the rash, but also how to use mogamulizumab, how to monitor it, how to react regarding side effects, and so on. This paper is since 2 weeks online. It's a recommendation from our cutaneous lymphoma group in Germany, and I believe it could be helpful. Finally, I want to go to the last antibody, which is not human monoclonal antibody. It is a fusion protein. So it's an antibody which is compared with a toxin. And the antibody is against the CD30 molecule, which binds to the ligand on the surface cell. And then the drug is internalized and the toxin is splitted from the antibody. And the toxin here, it's called MMAE, it's monomethyl auristatin E. It blocks the spindle apparatus, so it blocks the mitosis. And by this, the cell goes to the apoptosis and dies. The target CD30 is very often expressed in several types of cutaneous lymphoma. And that's the reason why this drug, compared to MOGA, which is only approved for MF and Sézary, the brentuximab vedotin is approved for CD30 positive cutaneous T-cell lymphoma. So you can use it for every type of cutaneous T-cell lymphoma who shows CD30 expression. There must be just single cells, not more. There is no cutoff of 5 or 10%. If you find CD30 positive cells, then you are within the approval and can use the drug. CD30 itself was first discovered, you see in the picture, some years ago. On the right side it's me, and on the left side it's Harald Stein, who was my PhD supervisor. And he discovered for the first time this molecule CD30 in an attempt to identify the biological background of Hodgkin's disease, which was not known in the 80s if it's really lymphoma or not. And he could define that this disease is a CD30 positive lymphoma, Hodgkin's disease. And based on this drug could be developed. For this, we have also a huge study. It's so-called ALCANZAR trial, where brentuximab vedotin is compared into standard treatment, which we have also in Europe. And the standard comparator was methotrexate in the dose of 5 to 50 milligram or bexarotene. So drugs we are using daily for cutaneous T-cell lymphoma for advanced stage, and we know its value. And brentuximab compared itself with 2 standard drugs for in patients with Mycosis Fungoides, in the trial having at least 10% CD30 positive cells, and patients with primary cutaneous anaplastic large cell lymphoma, which are by definition, of course, CD30 positive. The primary endpoint here was not progression-free survival, it was overall response rate, which worked at least for 4 months. That's why it's called ORR4. And here you see the study design again. So patients got one arm brentuximab and the other arm methotrexate or bexarotene based on the physician's choice. And coming to the results, you see about 4 times higher response rate in using brentuximab compared to our standard treatment. So this was really astonishing, or let me say also a big revolution. And which was also interesting is that it not only shows a higher overall response rate, but it shows also better progression-free survival, brentuximab compared to methotrexate or bexarotene. For both, for patients with Mycosis Fungoides and also for patients with anaplastic large cell lymphoma. And what we know also, meanwhile, we see it at the end, the 3-year overall survival rate. So mentioning overall survival rate in cutaneous lymphoma is something very rare. For other solid tumors like melanoma, it's an absolute standard. And for us, any drug which improves overall survival in cutaneous lymphoma is something new. And this study shows that the overall survival, especially for patients with advanced stage, improved with brentuximab compared to bexarotene or methotrexate. And it works especially well for the advanced stage disease. This is one patient which was in this study trial who have disseminated tumors. Also here patient study from a patient from the States who has huge tumors and got just brentuximab monotherapy. And although there were only single CD30 positive cells, or the pathologist rather judged it as CD30 negative, as mentioned in the title of this manuscript. And that means, although you have sometimes very low CD30 positive cells, you could achieve this huge response, as you see on the right side. Based on these new drugs which we have something in our hand which we could combine with the idea to enhance the effect regarding overall response, but also to prolong the response in terms of progression-free survival. And this is my last topic, where I just want to give you some single ideas. These treatments, brentuximab vedotin is an ideal partner to combine it. We learned it from our friends from the hematology. It's a standard for them in Hodgkin's disease to compare brentuximab vedotin with BCOP or with other combination chemotherapies or single agent chemotherapies like gemcitabine. So it works very well. So we have this possibility. Mogamulizumab has, beside the rash, is usually well tolerated. In brentuximab, of course, I have to mention one of the major side effects, which is common, is peripheral polyneuropathy. This is very common, and you have to ask patients before giving any infusion if he has any disturbance regarding his sensibility, especially peripheral sensibility on the hand, on the feet. Moga is very well tolerated. Of course, you can have the rash. Gemcitabine in the low dose is also well tolerated. And total skin electron beam is also very safe treatment, especially if you use a 12 gray or only 8 gray. And what we have done here in our clinic is just to give you an idea to combine brentuximab vedotin with low dose total skin electron beam, which my colleague, Matthias Eumans published about 3 years ago when we had our first 4 patients. And the principle is, the concept is very easy. We gave at the same time brentuximab and total skin electron beam. That means in the morning we gave brentuximab, in the evening we gave this 4 gray total skin electron beam. And the brentuximab, we gave it a normal schedule every 3 weeks, as is scheduled also for systemic lymphomas. And the total skin electron beam, we gave it just 2 by 4 grays, so Monday 4, next Monday again 4, and that's it. By this, we have a very good additional, and I think what we know meanwhile also synergistic effect of this combination. And we were astonished once we gave this for the tumor stage patients that already after 1 week, you see our first 4 patients. The picture in the middle is already after 1 week. And the picture on the right side is after 8 weeks. So this combination shows, first of all, a very fast response and also a very deep response. So during the treatment, 3 of these 4 patients got a complete remission of tumor stage. And I will show you also some more details about these patients. So this lady, she was the first one we treated. She's December 21 with the combination. Then she got, after 6 to 8 cycles, brentuximab with complete remission. The maintenance week with methotrexate, only 50 milligram once weekly. And you see this picture in February of last year. And I've seen her also in November last year, but I have no recent picture, and she is still in complete remission. Here's another patient with a tumor stage. We got it in summer 22. We see it 1 year later, and the patient is still in complete remission. And meanwhile, we gathered more experience. We have treated 14 patients with long-term follow-up. All of them have tumor stage, and all of them got maintained after the 6 to 8 cycles brentuximab combined with the 8 gray total skin electron beam maintenance treatment. I always recommend, once you have an advanced stage disease or you have a successful treatment, you have to provide him a maintenance treatment. which could be methotrexate 15 milligrams once weekly, or retinoid, or interferon. But you have to give him something, otherwise all of these patients are getting relapse within 6 months. And in this patient, you see it on the left side, our experience in these 14 patients with the tumor stage. All of the patients responded, compared to 68% in the Alcanza trial, where the patient got it as a monotherapy. And of course, we are comparing only stage 2B to 2B, because our patients had all of them 2B. And you see that's the overall response. And complete remission, sorry, overall response 100%, complete remission, it's about 64% compared to 60% in the Alcanza trial. And of the patient, other patients who got not a complete remission, we had 6 patients who had a partial response. And of these 6, 2 of them have a very good partial response. That means improvement of at least 75%. Interestingly, none of the tumor stage patients who got a relapse got a relapse in form of a tumor stage. So they got the relapse in form of patch or plaques, but no one got a tumor as a relapse in this observational time. And you see mean time to response, what I also mentioned, 1.7 weeks in the combination compared to 11.9 weeks as a monotherapy. So coming to the end, and also to leave some time for discussion, I want to summarize. Most important thing is, of course, to define the right diagnosis. You always have to differentiate cutaneous lymphoma versus inflammatory disease. If you are not sure, never give a biological treatment. You have learned from dupilumab in the last years, and I think most cases were wrong diagnosis. There could have been MF from the beginning, but all the patients got within a short time of progression of their cutaneous lymphoma. So never give a biological if you are not 100% sure that it could be not a cutaneous T-cell lymphoma. Then you have to find the entity, it's MF, it's cellular or blast lymphoma and so on, to define the stage. In the early stage, you start with skin-directed therapy as a first line. As a second line, you combine skin-directed therapy with systemic treatments. For the late stage, I think we have meanwhile very good treatments in our hand, which we can use as a monotherapy or also combination therapy. And then it's up to you and up to your experience. I know in the Middle East that usually the advanced stage are more often treated by hematologists and by dermatologists. That's why this multidisciplinary working is very, very important. However, also we do it in Germany by ourselves in the major clinics in dermatology, but we also discuss it in a multidisciplinary team, especially for the advanced stage patients. For this, I thank you for your time and also thank you for your attention.
Thank you, Professor Assaf. Thank you for your valuable talk. And now I have to say 2 things. First, again, there are some of the audience that they have not changed their names. Please change the name of your IDs from the name of your phone, from your own name, because we want to give certificates but in your own names. Also, if any of the audience have any questions, we would be glad to have your questions here. Is there any question? I'm sorry. I would.
It looks like I answered everything for my talk.
Yeah, perfect. Of course, I have a question. I'm here with one of my colleagues at the hospital, Professor Shakir
Nice to meet you.
also. Just one question that we have in the clinics is for those patients with follicotropic MF, when they have lesions on their heads, And because we're trying to launch this total skin electron beam, we want to know that would you give the radiotherapy to the scalp also or not?
If the scalp is involved, yes. If not, there are possibilities to leave it out, to leave the scalp out. So that's what my colleague, you know him, Dr. Daumazian, is doing. So if it's, let me say, in the front of the face, and of course other lesions on the skin, then he's giving total skin. But he has something like a device, what he used also, which is also known for patients who got in chemotherapy. Or this device is something like it's like a metal helm, nothing special. It's a metal helm
Yes.
that the radiation is not going through the scalp, and then he's evaluating the rest.
Yes. Great. Also, another question for this low dose gemcitabine that you said half the dose of 1,200 milligram. It means 600 milligram. Yeah, if I'm right.
The normal dosage is 1,200 milligram per square meter, and
200
uh,
milligram per square meter.
yeah, and here it would be about 600 milligram per square meter. Yes,
Uh, Day 1 and then day 15. Yes.
yes, yes.
And how long would you continue? Only two doses, or for example, 3 months or 4 months?
6 months, for six
For
months.
6 months, every
For
two
6 months.
weeks with a dose of 600 milligram.
Yeah, 6 months, and
Um,
yes.
do you have Professor Shafrinejad? There are some questions in the comments. Uh, do you have any experience about topical lamustine? I think is
I
it
think topical
carmustine?
lavostine is something like topical carmostine, which is
Yeah.
an alkylans. And carmostine, we used it about 20 years ago because we had to do it as an emollient by ourselves. But now we have the drug, which is clomiphene gel.
Yeah,
Clomiphene
yeah,
gel,
prometheine.
it's a clomiphene. And clomiphene is the same principle. But you can buy it. The drug name is Ledaga.
Ledaga, with the brand name of Ledaga, yeah.
Ledaga. The brand name is Ledaga, and you use it. It works well for the early stage. And sometimes if you have an advanced stage like single tumors, but you have patch and plaques, then you can combine it also with a systemic treatment. Works quite well. However, you have to take care since about a quarter of the patient are getting a so-called dermatitis, local dermatitis. And for people who don't know it or have not experienced, sometimes I think it could be a relapse of the disease. But it's just, it's like irritative, in most cases, an irritative dermatitis, and maybe in 10% a real allergic type 4 reaction. And in these cases, you have prolonged the treatment to give, instead of giving every day, to give it every second day or once a week. Or what we recommend in Germany, it's also been published also 2 years ago, that we combine it with topical steroids. Topical steroids are also first-line treatment. So day one, we are giving Ledaga. Day two, we give something like mimetazone ointment, and so on. By this, we reduce the risk of the dermatitis, and we have also, at the same hand, combination therapy.
Great. There is another question. Do you have any experience regarding using dimethyl fumarate in any stage of MF?
This is a very interesting question. Dimethyl of course, are not approved for CTCL, but we have published, I think, last year, phase 2 study, where we gave, it's a German study, where we gave dimethyl in the normal dosage as for the psoriasis patient, and have seen a response rate about 25 to 30%. It seems that it works, especially you see it in patients with blood involvement in the beginning. But what we can say definitely, it's not enough as a monotherapy. It
It's
would
not
be,
enough.
it's not enough.
Would
So
you combine it with, sorry
we are
to interrupt.
planning, we are planning now to do a combination study
Mhm.
of, and there are also some data where you can combine it very well with extracorporeal photopheresis.
For advanced stages or for early stages?
for advanced stage. So from, let me say, from, we have also included 1B patients for refractory 1B, and especially for disseminated 1B or erythrodermic patients like erythrodermic MF or Sézary, both.
Thank you. Also, and also they have asked, Professor Mahmoudi has have asked about JAK inhibitors. Would you give JAK inhibitors to MF patients?
I have I have just started 3 weeks ago to treat a patient with JAK inhibitors. I have no personal experience in JAK inhibitors. They are also not approved. And regarding JAK inhibitors, I think you are by yourself the best expert. And what I have learned by your work and your colleagues is that we have 2 prospective trials where the response of JAK inhibitor is limited, only something about 25%. And in some cases it's worsening, in some cases we have a low response. And it seems if we use it for a T-cell lymphoma, it works best for subcutaneous panniculitis like T-cell lymphoma.
Exactly. Just we wrote a review article together. It is effective for some types of subcutaneous T-cell lymphoma. Also for some cases have shown efficacy, but there are some cases that have worsened with JAK inhibitors, and still we are not sure that it is an effective treatment. Also, Professor Shakuinejad has a question. I will read other comments. Okay, you can
Do you have any experience on a folliculotropic MF or ichthyosiform Mycosis Fungoides?
Sorry, experience with folliculotropic?
And folliculotropic Mycosis Fungoides and
together,
and ichthyosiform type.
Of course, I see a lot of folliculotropic patients, and I have some patients with ichthyosiform, maybe 2 or 3, not so much, but they look ichthyosiform MF. But none of these patients have a combination of both.
No combination.
Okay, yes, we are treating the folliculotropic MF usually, usually with a systemic treatment like interferon in the beginning or retinoids, depending on the age, depending on the concomitant treatment. So if a patient has already elevated liver blood lipids, we don't like to give him retinoid. If a patient is very active in his life and interferon could be difficult sometimes. So these are the reasons once we choose interferon or retinoids. And yeah, and of course, total skin electron is for both very, very effective. But usually, especially in the ichthyosiform, they are receiving first-line standard treatment. That means they're getting Pova combined with retinoid or interferon.
Thank you. Thank you so much. Also, Professor Gandhi, the chair of our department, has wrote for you a message. I don't know if you can see the comments. Can you see them? Yeah, I read instead of her. I just
Yes, I see
wanted
it.
to, yeah, personally, she wanted to thank you for your valuable presentation. And I don't see, okay, I will ask. I don't see any other questions. Also, Professor Shakuinejad has once had a patient with muscle involvement, MF patients that her muscles were involved.
I have a patient with ichthyosiform Mycosis Fungoides and myopathy and the muscle and fascia's involvement. Do you have any suggest for treatment of her? She gives
So is she,
methotrexate and interferon and narrowband UVB and brontoximab, but she doesn't treatment.
So he has ichthyosiform Mycosis fungoides.
Yes.
So it's patch and plaque-like. In addition, myopathy.
Yes.
And once I hear myopathy, of course, I always think first if it could be a side effect of a treatment, like retinoids. Retinoids can induce myopathy.
No, the biopsy of muscles showed mycosis fungoid involvement.
Oh, Oh, this is very rare. I have no own patient by this. I know a little bit the literature on these rare cases, and that means it's very unusual, I must say,
Yes.
because if you have patch and plaques, the lesions are usually within the dermis or superficial dermis. They are not going in the deep. They're not going in the fat like the tumor.
Yes.
But once you have muscle involvement, that means the cells must go below the fat through the fascia in the muscle.
Yes.
This is something strange, I would say first. And then I would have to exclude if he has blood involvement. If he has blood involvement, I could imagine that by this, like MF with blood involvement or Sézary syndrome, sometimes in MF you can also early stage have blood involvement. Then you can have infiltration also of the muscle. Yeah, then then you need a treatment which works very good for the blood. The best drug which works for the blood that we have, it's mogamulizumab, where you can titrate the malignant cells within weeks. And the question is, if you don't have mogamulizumab, what could you do? That's what we know from our previous experience. Method gemcitabine is working quite well for blood involvement, and then I would, of course, give him the low dose schedule.
Thank you.
But I would check for blood involvement.
Dr. Mahmoudi, could you please ask your question? And there is someone, I don't know, Dr. Fateme, because I don't see.
That's the question regarding overall. I see the question from Dr. Mahmoudi regarding
Dr.
overall
Mahmoudi
survival.
is going to talk, I think, because I asked him to turn on his microphone. I think it's on, but I don't know why we can't hear him. Dr. Fatema, could you also
I hear you.
Yeah. Could you also activate your microphone? How long can we use interferon for mycosis fungoides? Is there any limitation?
Okay, do you hear me?
Yeah, I can hear you, but I'm waiting for Dr. Mahmoudi because he wanted to ask I asked him to ask by
I see the question from Dr. Mahmoudi in the chat regarding the improvement of overall survival. We have recent data that brentuximab vedotin shows an improvement of overall survival in the advanced stage. We have a recent publication some months ago that mogamulizumab improves the overall survival in patients with Sézary syndrome. And we know that patients who are receiving extracorporeal photopheresis is also improving the overall survival. There's one very good study from the French group from Paris, published, I think, in September last year in e-medicine. The last author is Adèle Desmassons. So it's something very new to have data for overall survival, but let me say in the last 18 months, there are some data coming. Regarding the interferon, I give it dependent from the response. If the patient is responding, I give it. If he's not more responding, I have to change it, or I have to combine it with something else, like phototherapy or radiation therapy. And the limiting cause usually are the side effects. That means side effect on the blood, pancytopenia, on the liver, or sometimes on the symptoms regarding fever and joint pain. That are or sometimes losing weight. So these are the common side effects I see with interferon. Depression is also reported by, I never have seen it in my life, neither in the lymphoma, neither in the melanoma patients, where we used it very often previous time, that they are getting a depression from the drug itself. That's not.
Yeah, Dr. Mohagef, yeah, because now I can see her family name. And how about PUVA? How many sessions can we use?
I think you are better than me regarding PUVA, depending on the skin, depending on the skin type. What What I'm not doing, but my situation is different because the risk of skin cancer and so on is much higher here in my Professor Tsami, we have seen our patients, they are all of them have a very white skin, and if you elevate a little bit the dose, they're getting very fast to dermatitis. So it's what I can say, I'm not giving phototherapy as a maintenance treatment. Some people are doing it, but for our patients here, the risk of squamous cell carcinoma or BCC is elevated. That I just give it for the normal schedule. Once I have the feeling that the patient could get a relapse within a short time, then I give him either maintenance treatment or systemic treatment, like methotrexate once weekly, 15 milligrams, or acitretin, 25 milligram, 1 capsule once a day. So these are my treatment of choice at the early stage once I combine it with phototherapy.
Thank you so much. If I can't see any other questions anymore, it was a really, really great pleasure for us to have you in this webinar. Thank you. It was very informative. And Dr. Muharraq, about the interferon, Professor Assaf said that we usually have to discontinue the drug because of the side effects, but the duration, I think, as I have understood, has no exact limitation.
Exactly.
Okay, and just thank you everybody for participating in this webinar. Thank you for giving us your valuable time. And I hope that we may have more of these sessions if you have time. And I don't have anything more to say. And I can say goodbye. If you have any comments or...
No, it was thank you. Thank you for the invitation, and it was a pleasure for me. And the discussion was also very, very good, I must say. Very interesting questions. And as Professor Gambi already wrote, thank you for your words. I'm looking forward for more cooperation.
Thank you so
I wish you all a
much.
great day.
Have a nice day.
Thank you.
Goodbye, everybody. Thank you. Thank you
you.
so much.
Thank you. Bye.
Bye.